Hello, everybody. Good afternoon. I'm Allison Elsner, and I'm CEO of the San Bernardino County Medical Society. And we are so excited that you are all able to join us today for this awesome webinar. We are very thrilled to have two amazing speakers with us who are great partners for the Medical Society and the medical community within the Inland Empire for our webinar, Primary Care and Pregnancy, Improving Outcomes for Black Birthing Individuals. So I'm going to go ahead and just introduce them. Feel free to enter your questions into the chat as the speakers are presenting, and then they can either take your questions, they're going to just, it's going to be kind of informal here, or we'll wait till they're finished and we'll go through your questions. So if you think of something though, go ahead and put it in there so they can address that. So we're very excited today, first of all, to welcome first our past president of SBCMS, Kristy Roloff, DO, MPH, Maternal and Fetal Medicine, Obstetrician Gynecologist with Valley OBGYN Medical Group. Welcome, Dr. Roloff. And we're also very excited to have Kendra Flores-Carter, DSW, who's program director for the NAEBOR Clinic. So you're going to be hearing a lot today about the NAEBOR Clinic and about ways that we can bridge some gaps between primary care and developing maternal care plans for all of you that will really benefit your patients. So Dr. Roloff and Dr. Flores-Carter, we're going to turn it over to you. Take it away.
Hello, everybody, and thank you so much for having us. Allison, thank you for the kind introduction and for your continued partnership and collaboration. It's just always a pleasure to work with San Bernardino County Medical Society. And we're excited to come and bring this information about a project that Dr. Flores-Carter and I have been working on along with others. We'll introduce you to the whole team for about 2 years now. And we're excited to let you know how the preliminary data has turned out from the first year of this project. Dr. Flores-Carter and I are very much looking forward into getting into the newest data, but we haven't quite got there yet. And I do want to also give a shout out to First Five. This is a grant-funded project, the NAEBOR Clinic, and we couldn't have done it without their support. My role is in the NAEBOR Clinic. I'm a maternal fetal medicine physician. I do see some of our patients if they need high-risk services, but mostly I work with our team to make sure that it's working for Black and African-American birthing people in our county. And Kendra and I co-direct the program. They're both heavily involved. Kendra, do you want to introduce yourself?
Yeah, hi everyone. Thanks for having us. I really appreciate getting our information out there about this amazing clinic. I am really an honor just to be able to share stories of how this came to fruition. I'm the program director for social services mainly. Dr. Roloff handles the medical side of everything that we do, she's awesome. And I really am happy to see you all here. So I'm grateful to have you all here to kind of hear more about what we do for our community here in San Bernardino County. And yes, thanks First Five for giving us this opportunity. I serve as a coordinator for community outreach. I do a lot of the training for NAEBOR. That we do culturally responsive training for all of our NAEBOR staff. And so I'm really excited to continue on this path with Dr. Roloff and Dr. Valenzuela. So thanks.
So before we get too far, I should tell you all what NAEBOR stands for. It stands for Neighborly Adaptable Equitable Care for Black Obstetric Patients with Respect. And the reason that this program even exists is unfortunate because we know that Black birthing people in the country, and our county is not unique, experience greater proportion of maternal morbidity and mortality. And so watching this from our end in delivering babies at Arrowhead Regional Medical Center, both Dr. Valenzuela and I felt like we needed to be part of the change to make this problem be a non-problem. We needed to be the change you wanted to see in the world. And so that's really why this program started. Kendra, I think, has a really unique perspective and story about how and why she's involved. So I'll turn it over to you, Kendra.
Yeah, absolutely. I think, I have worked with Dr. Roloff and Dr. Valenzuela for many years. And we work together on the team, on a multidisciplinary team at Arrowhead Regional Medical Center. And so even when I left, I had always wanted to be involved in being the change that Dr. Roloff is talking about, especially as it relates to Black women and experiences they have within the healthcare system. And for me, once I started having my children and I started learning more about the disparities in healthcare, I realized that there was something that we really had to do. And so, I just started talking about my story and my experiences with Dr. V, Dr. Roloff, and it just kind of came to fruition where we one day just all sat down and was saying, let's see if there's something that we can do. And we put a proposal together and we started thinking about ways that we can impact and help the community, especially Black women, to have better pregnancy experiences and outcomes. And so this is really where the whole NAEBOR idea came to fruition, is just us really having the conversation, me having an interest and a passion of really wanting to do better and also service my community and working together with people who also really saw that there was a need to improve the care that they were receiving as it was related to maternal health. And so that's really where we started the conversation, and it just kind of ran from there. So yeah, so Dr. Roloff.
Yeah, one of the things Kendra said to us very, very early on was, I want a provider who looks like me and who shares my experiences. And even if they don't look like me or share those exact experiences, I want a provider who understands that and knows to listen. And so we went into this project with 3 missions. The first of which was to develop a clinic that's tailored to the needs of our specific community. And that's where representation really does matter. And we wanted to make sure that people and the staff and the folks creating the program were from the community itself.
Yeah.
And so Kendra's really been a big part of that.
Yeah, absolutely. We really wanted to make sure that we looked into improving outcomes and what were ways that we could do that. What did we need to implement? How did we need to shift? And what tools did we need to use to see how we were doing that? What training did we need to bring in? And so one of our mission was really to improve pregnancy outcomes and the patient experiences. And so we worked together to really see how we could bring that to fruition.
And then along the way, we also heard from the community that they wanted to have care that was very much patient-centered and tailored to them and their specific needs. And we recognize that this isn't going to be a one-size-fits-all type of model of care like we are used to delivering, where we are going to need to incorporate televideo, telehealth, alternate visits, alternate schedules, increase number of appointments or decrease number of appointments based on both the risk, the medical assessment, but also the social and psychosocial assessment of the patient.
Mm-hmm. Yeah, so we definitely decided that, okay, we have this idea, we have this proposal. Now we wanted to bring our team together. And one of the focus was really, we know how important representation was. So we really wanted to create a team where the members on the team would look like the patient population that we serve. And so we try our very best to make sure that, from our medical assistant, Destiny Pan, we have Danette Brown, who's a physician assistant, and our patients love her. They come in, they want to give her a hug, they bring her gifts because, again, she is really, welcoming them into a space that's safe and wanting to let them know that their voice is going to be heard, right? We had Dr. Coleman, and we have Dr. McIntosh, who plays a vital role, and I'll explain that a little bit more later as we go throughout our presentation. But she's a LCSW, a licensed clinical social worker, and one of her goals is really to connect that behavioral health piece. We have Dr. Roloff, who is a major part of the team as far as making sure that our high-risk patient gets seen and screened, and we're doing everything we can to follow them. And of course, we have Dr. Valenzuela, who really creating and gave us the opportunity to have this vision, right? We have Dr. Coleman, Dr. Okepi, who's also a part of this grand team that we have going on.
And I'll touch on this in a little bit, but one of the hard things to do when you're trying to create specific services for Black birthing people is recruiting and retaining Black physicians. Unfortunately, they're very underrepresented in medical school and actually underrepresented in the healthcare industry. And so one of the things that we've learned along the way is that we need to create pipeline programs for physicians, mid-level providers, medical assistants, all of the support staff. And so that's going to be part of the next phase of NAEBOR, is really education and pipeline development of that workforce. We launched in September 2022. Thank you, Kendra, for reminding me of the date earlier. At a clinic, we're located within the Mommy and Me practice on Foothill Boulevard in Rialto. And about 3 months ago, we launched our second site on Orange Street in Redlands. So we are operational. We went from 1 day a week seeing patients in the NAEBOR clinic at one site to 5 days a week between 2 sites over the course of 2 years. All right, so I touched on, not doing just standard prenatal care. And these are the pathways we created for our NAEBOR patients, where they could choose at their initial visit what model of care is right for them. And this isn't just based on the provider's assessment of the pregnancy risk. This is based on her perception and her needs for the pregnancy, recognizing that we aren't just providing medical care, but we're also providing social services, community health care, mental health services, and additional support through the pregnancy, because it really does take a community, not just to raise a child, but to have a healthy pregnancy. And so we offered the traditional care model of in-office visits with the standard 10 prenatal visits occurring roughly every 4 to 6 weeks in the first trimester, every 2 weeks after 28 weeks, and then weekly after 36 weeks. But we also offered a telehealth path with 4 in-office visits. These would be coupled with like the first prenatal visit, when you can do a complete physical exam, medical assessment, lab draw, ultrasound. And then the in-office visits were always timed with those additional services that they could be provided at the same time, such as the anatomy ultrasound, where you do need to be physically present. We haven't quite figured out how to do ultrasound virtually yet, someday. And then the in-between visits, we would have the patient check her own blood pressure. At times, even if they had a fetal heart rate Doppler, check their own baby's heart rate, really empower them to do a component of their care in a supported way with us. And then we also recognized that even in not high-risk pregnancies necessarily, although of course intense care would be appropriate for high-risk pregnancy, where maybe they need to be seen more often for conditions such as chronic hypertension, we also recognize that some people just need a little additional care. And if they want to come in more than the 10 visits, then we'll do that. We'll offer intense care and we'll support them where they need to be. And so we offered these 3 models of care. And this was largely based on evidence from the Michigan Plan for Appropriate Tailored Healthcare. And this is supported, this model of care, where we take average risk pregnancies and we sort of don't squeeze them into our traditional box. If you need to come in at this number of weeks, we sort of say, we're going to give you this flexibility. We're going to meet you where you need to be based on your work requirements, life requirements, childcare issues, travel, vacation, all of those things that play into our lives during the 9 months of gestation. And this Michigan plan is supported and vetted by ACOG. I'm not sure why it hasn't really taken off, where we sort of say these, non-traditional models of care can really be offered, but there is quite a bit of evidence that this can benefit patients and increase their perception of trust with the healthcare system and their satisfaction with the care we provide antenatally. Interesting though, despite offering all of this and doing this in an evidence-grounded way, not a single patient has chosen anything but a traditional care model. And so what we're learning from our patients is that maybe we don't need to deviate as much as we sort of thought that we did. And so we'll see. I don't know if over time the perceptions and the needs are going to change. So I think that these different alternative paths are important to keep open, important to explore. But again, I think it's very important to listen to the community and do prenatal care in a way that she wants, that they're telling us to do. This is just a little bit of an explanation of how the Michigan prenatal care path works. It really is about more than the standard ACOG antepartum care model, where we address the medical determinants of health. It's not just the schedule of visits that's flexible. It's really taking a look at the whole person and the whole person care and adapting what we do for the social and structural determinants of health that include material needs, psychological needs, social needs, as well as their demographic characteristics. And so instead of just saying that the medical needs should dictate the visit monitoring frequency, we also look at how we can incorporate ancillary telehealth services, home devices, home monitoring, and then the non-medical services such as social services, community health services. We do partner a lot with our community-based organizations to make this an effective collaboration. And this is kind of that Venn diagram of how that all comes together. So Kendra's going to kind of explain a little bit more about how we integrate all of this.
Yeah, absolutely. I think one of my background is in social work, and I know some key things that we do is like assessments around your social needs, right? And seeing from that biopsychosocial assessment, what are the needs that the client have and how we can connect them with their needs. So part of the role of a social worker is really just being in there to make sure that, for instance, we're connecting or moms with doulas, right? Making sure they're connected, they're educated around how a doula can support their pregnancy, connecting them with Black Infant Health for that supplemental support outside of the clinic setting, right? We know that Black Infant Health offers an array of different programs, things from helping moms with provisions to helping them to get diapers and wipes and support for breastfeeding, support for various things that they may need during the pregnancy. So having that support is really important. And that's how social workers are able to connect or patients to these direct agencies outside and community organizations outside. Our social workers are also assessing for mental health needs. Dr. McIntosh is an LCSW. She's a licensed clinical social worker, so she's able to see our patients if they have postpartum depression or they're experiencing depression during pregnancy. She's able to really meet with them and help them to cope better during the pregnancy and help reduce any symptoms, that they might be experiencing during that pregnancy period. We have our community health worker, and they're really to help bridge that gap, right? They're a key part of our healthcare team, and they're able to help the patients to fill those gaps between the medical needs that they have and the needs and wishes that they may desire, right? So they're able to connect them with that piece. And then we also have our medical provider. And so we all work together as a team to ensure that kind of holistic approach to care, making sure that we're providing that not only care in the hospital, but outside, and also that continuum with the community health care workers. So Yeah. I don't know, Dr. Roloff, you probably have more to add or, but yeah.
I always add more, don't I? Just a little bit on the science behind the community health worker. Community health workers have been largely deployed in primary care settings. And it's an unusual thing to find community health workers who are specifically trained in the maternal health care space. This has been implemented in other areas of the country, a little bit more so than in California and particularly in the Deep South. And this is just one study that shows that community health workers really do have a positive impact on knowledge birth outcomes. And so we're really excited to have integrated community health workers into our model of care. And the way we've done this is by taking our medical assistants, training them to be medical assistants, and then having them go and do community health worker training. And so we've hired our medical assistants from the community that we're serving. And then super exciting, our first cohort that went through NAEBOR takes about a year, right, to have a pregnancy and have your baby. After the first year, we offered community health worker training to our patients as sort of a pay it forward model. You went through the NAEBOR clinic, you accessed the social worker, you figured out how to interact with the medical provider, the community health worker in a way that benefited you and your family. Now let's train you because you're from this community. You can give back to, let's pay it forward. And so we had 3 of our patients undergo community health worker training. And we hope to keep them engaged in the NAEBOR clinic. And also hope to offer them employment opportunities as we continue to develop this piece of offering prenatal care in this integrated way.
Yeah, absolutely. And 2 of which are expecting again or community health workers. So they're actually returning to the NAEBOR clinic for a second time because they're pregnant again. So yeah. Okay. And we have our social workers. I think I explained that pretty well. So Dr. Roloff, it's back to you.
Okay, so our social worker largely connects the patients with our community partners, and we've been fortunate to have such strong community-based organizations as well as strong relationships with the Department of Public Health and their programs, which are designed to kind of, it's like a coordinated mission, right, to reduce Black maternal morbidity. And so all of our patients get referred to, if they want, nobody's forced to do anything, but they all get referred to Black infant health. And the majority of the NAEBOR patients do attend the Black maternal, or sorry, the Black infant health program sessions. We've been fortunate to connect both with IEHP and as well as with Sankofa birth workers to provide doulas for our patients. And interesting, in the first year of the program, we saw a very poor uptake in doulas. Also, it's actually, I don't know if anyone out there is practicing in obstetrics, it's actually very hard to get a doula through IEHP or Medi-Cal right now. They're kind of in demand. We don't have enough, especially Black doulas in the area that can support our patients. And I think we're in a unique situation where we can work with doulas as medical providers in that coordinated way where it's not an antagonistic relationship and where we can support hospital-based safe birth practices. Just as kind of a side note, but while I'm thinking about it, one of the things that happened ancillary to this NAEBOR clinic is that at Arrowhead Regional Medical Center, we, about a year and a half after we started NAEBOR, were awarded a national award. Only 20 or so hospitals in the country were recognized by U.S. World and News reports for a low primary C-section delivery rate, as well as low rates of unanticipated newborn complications, specifically in Black birthing people. And so I think pulling in the Black doula, pulling in the Department of Public Health, Black infant health initiatives, working with perinatal equity initiatives, the Maternal Health Network, which Kendra is really involved with, as well as pulling in other organizations like Fathering. We have a connection with Children's Health Network that gives cribs, promotes safe sleep practices. We also, as part of the NAEBOR clinic, work closely with the incarcerated released population. It's a very high-risk population in our community. And it's just really benefited the community as well as our relationships with our patients.
Yeah, and if I can add, I think that we've had several of our community partners actually come to our neighbor clinic to kind of give us in-service so we can get more of an in-depth look at how they can assist and help our patients. And so we're definitely always open to having you come out and, give just some information, some more in-depth information. If there's any partners that are out there today on Zoom who are interested in really wanting to share your resources with NAEBOR, please go ahead and reach out, because we would really love to partner with you all and really kind of share referrals and do as much as we can do to improve the outcomes for our Black serving populations. Okay.
So where do we go next? And I've touched on this a little bit. The lessons that we've learned is that there's not a very stable workforce, and there isn't a large push to get Black and African American people to work in healthcare, much less in the maternal or obstetrics care space. And so we are looking towards the future, towards creating the pipeline of community health workers. And we are now exploring options to embed and integrate doulas into the clinical office setting as opposed to into the home setting with the patients to provide better access to doula services. And maybe we'll get to the point where, and we did this way back in the day at Arrowhead, but maybe we can get to the point where, doulas are staffed on labor and delivery units, and they're just really part of routine care and not an exception. And we still have some work to do with our patients to get them to accept this kind of a service that we know is beneficial, and also a little bit of work to do to get the doula community to integrate better with medical care providers, to recognize that we're all on the same page ultimately, and we want the best in it for the health of the baby and the mother. So I guess the next step is to create an ancillary support training pool and a pipeline so that we create the village that takes care of the person. And I think this is going to be applicable not just to Black birthing people, but to people of all minority ethnicities, as well as all people of low socioeconomic status that really have this need.
Yeah. Okay, and so I just want to kind of share that NAEBOR is a medical managed or indigent care practice. We accept all forms of IHP, Molina, presumptive eligibility for medical. And one of the things that if a patient comes in and we know they're pregnant and they've applied for Medi-Cal and it's pending, it's going to be coming, we're able to still see them for that first visit until their medical becomes full service during the pregnancy. We unfortunately, we don't always see patients who have commercial insurance, HMO, PPO, and for various reasons, there's a reason why we can't, because we're not able to receive any reimbursement. We definitely want to kind of shift gears a little bit here and go into looking at some of our first year experiences through our data, and Dr. Roloff will go through some of that with you all.
So in our first year, and we've just told you we've now been operational for 2 years, but I have the data downloaded. I haven't quite dug into it yet, but I hope to get you guys publications and information about the second year total experience. But in our first year of operations, we had 26 patients, 1 miscarriage, and 1 incarcerated patient that finished her care with our NAEBOR clinic. We surveyed these patients, and they were really gracious about filling out all of our surveys and giving us all of the information. So I actually have over 500 data points now. I think I'm up to something like 1,600 data points that I have to analyze. We had 6 babies. Of course, we enroll early in the pregnancy, and so a lot of the babies didn't come through in that first year. And we had 7 or more events that we did in the community and created those strong relationships with over 10 community-based partners. In terms of who we saw in the first year, our referrals were largely from our existing practice at Mommy and Me. We did see referrals from Black Infant Health come into the NAEBOR clinic, and we did have some of our community health events and activities that we did pull in patients. We did have a radio spot that probably got us the patient as well. I will say part of the reason we're out here talking to you today, hopefully there's some primary care offices or providers listening. We'd love to see more patients. We do not offer individual services. This is a comprehensive integrated care model. So we can't take patients just for social services. It's really grant funded. And so it needs to be the whole care of the patient. But we would love to see patients from outside our existing referral networks. And so that's kind of what we're talking about, why we're talking about all this good work today. In terms of the referrals we made, you can see we made a ton of referrals to Black Infant Health. Like I mentioned before, Sankofa doulas. We were able to connect patients with food scarcity to food vouchers. We had a pretty good uptake in our fathers, connecting with San Bernardino fathering. And we only had 6 babies, so we didn't have anybody take us up on the community Children's Health Network crib program. But since there's been more babies this year born, now I know we're getting those cribs out into the community and promoting those safe sleeping practices. Kendra, do you want to talk a little bit about the social needs of our population?
Yeah. So when we look at the social needs, there's a various, most of our patients are from lower socioeconomic status. A lot of them sometimes are receiving services through WIC. Some of them do receive CalFresh. So we really have a population that have a lot of social determinants of health needs. And so we're really making sure that we're connecting them with those needs. A lot of them also have a need for transportation, which is where sometimes our social worker comes in with that telehealth piece. A lot of our moms are seeing the social worker through that telehealth piece. They do the virtual visits only because sometimes when they come in, a social worker is not able to see them. Like, she's there Mondays, and so if they come any other day, they might struggle, but she's able to see them any other time during that week for a virtual visit. So it really helps because of the transportation issue. As far as food, we've really worked with our community partners to be able to educate our moms around nutrition. But again, there's definitely a struggle there and a need for more education around how to help them to be able to learn how to eat more healthy meals throughout their pregnancy and postpartum period. Housing needs, we do have some housing needs, and I think Dr. Roloff is going to go over some of that data for us.
So these are the results of the social needs screening tool. We use the American Academy of Family Practice long social needs screening tool to survey all of our patients. And we found there's a fairly high, relatively high housing scarcity or threat of housing instability in this patient population, with about 7% not having stable living situations. And I think this is really kind of it's just a little bit heartbreaking, right? Seeing 7% has water leaks and just not living in safe spaces, and up to almost 12% had threats of, utilities being turned off within the next few months, and 4% had, already lack of utilities already being shut off for various reasons. In terms of food scarcity, it was similar to the rates of housing threats, in that 7.7% of our patients reported that they were worried they were going to run out of food before they would have their next paycheck or ability to get more food. And almost 12% said that the food they had was just not going to last through the week or the month. And so we did partner with Mayor Robertson to create the food voucher program, and we're able to get some healthy foods for some of the patients with this kind of a threat. But I just think these numbers are just shocking. We shouldn't ever be living in an area or a time or a place where that many people are experiencing food scarcity.
Yeah.
So about 12% similarly would put off visits or neglect going to the doctor for their own personal care because of distance or transportation issues. And of course, you all know in our county is so big geographically, and our high desert population is a really tricky population to serve. And we do definitely see patients that come down and see us from the high desert. And even more alarming and not surprising, unfortunately, but almost 20% of our patients reported that they had difficulty getting childcare that would prevent them from work, study, much less going to doctor's appointments. And so, yeah, it's just hard to find that community to take care of the child. And remember, these are pregnant patients, and they're already experiencing these with their existing, within their existing households. And it's just going to be exacerbated by adding additional mouths to feed and an additional need into that household. The financial stressors are quite significant amongst this population. Only 30% or 27% described themselves as never, as always having enough money to pay bills, right? So this brown portion is just the ones, it's too small of the wedge, the people who have enough money to pay their bills. This wedge where there's some threat of not having enough income to keep the household running is the majority.
Yeah. As far as safety, we had 3.8% that reported physical abuse, 26.9% reported rare or sometimes insults or talking down to. No patients reported threats of harm, and 15.3% reported direct screaming or cursing. And I think from what this is telling us, is that there definitely is a need for more resources around maybe family preservation and also safety in the home. There's definitely a need for more services related to domestic violence and how we can protect our moms during pregnancy and the postpartum period. I don't know if we have enough resources within our county, but from just our preliminary data, what we're finding is that there's definitely a need for resources around that, counseling and education around, of course, intimate partner violence. If we did have a patient who was successfully able to get out of an abusive relationship, Dr. McIntosh and I was able to work with that patient to get her into a shelter. She was able to get emergency I think funds so that she was able to move into another place outside of where she was living with her abusive partner. And she was able to be counseled on how to file a restraining order and really just be in a safe space and outside of harm's way. So social work is able to step in there and also support any one of our patients that's going through intimate partner violence. But there is definitely a need for more resources around education for this.
This is a great example of how the NAEBOR clinic works, right? We get taught about social determinants of health and taught about intimate partner violence as medical providers, but without that connection in the office and that immediate support, intimate partner violence, we know escalates during pregnancy. And so even taking one person out of 26 out of that threat of violence is just a huge win. And just not something that we can do in a traditional obstetric care delivery model. So it's very difficult to study in a small cohort actual improvements in maternal health outcomes or rates of morbidity. And that's just because there's just not that many patients. You need a really huge cohort to sort of see if your intervention is going to make a difference. And so our primary outcome that we're studying in this cohort isn't actually an outcome, although we assume perceptions of care, if they increase or improve during pregnancy, then we will impact maternal morbidity. And we are very proud. We had a pretty good report card. So we use a tool called patient-centered perceptions of care. This is a scale that's been validated in patients of all colors, and it included about a 25% cohort of Black patients. And so been validated to assess perceptions of care for Black birthing people, as well as other races, including minority races. And a lot of the scales that we have that assess perceptions of care really don't include those test subjects when they validate the scale. So we're pretty happy with this perceptions of care scale. We came in with a pretty good report card. I like to put say this is an A, B, C, D type score, because it's out of 100%. Our total score coming into the program for our patients at their first visit before they'd experienced the NAEBOR care model was pretty good at B, 87.2. And at the conclusion, at the postpartum visit, we were up to 94%. This particular scale includes different domains of dignity, respect, communication and autonomy, and responsiveness and supportiveness in the care. And you can see that we increased our scores, though they were very high at our baseline, substantially during the NAEBOR clinic. And so we are pretty certain this is going to translate globally to an improved experience, improved trust with the system, break down some of those barriers that have been built up from institutional racism affecting how healthcare is delivered. We also, of course, do our adverse childhood experience trauma screenings, and we do this for all of our patients, regardless of their race or ethnicity. But I think interesting in this population, you can see our mean score for our adverse childhood experience trauma scores was 1. And the range was 0 to 4. 4 is considered positive. And we know that experiences in childhood that are detrimental create toxic stress that increases the chance of both adverse pregnancy outcomes as well as long-term health outcomes that are poor, including diabetes, hypertension, cardiovascular disease, and the like. This particular patient population, though, doesn't have a problem with adverse childhood experiences. But let's look at their experiences with racism. Because if an adverse childhood experience, such as loss of a parent, divorce, or prison of the parent, if that contributes to toxic stress, how do you think racism contributes to toxic stress? So seeing a low score in a Black birthing person, to me, it doesn't answer the question of whether I need to be worried about whether toxic stress is affecting her health. And so we implemented this scale. It's called the Perceptions of Ethnic Discrimination. And it's a score or a scale that's appropriate for people of all minorities, not just Black people. And higher scores are indicative of more experiences with racism. A score of 17 would be no experiences of racism. So we did have some patients that had no experiences with racism that they reported. But our max score was 85, kind of off the chart, and our mean was 27. And to me, this says we missed the boat when we rolled out adverse childhood experience screening and didn't incorporate racism or markers of discrimination in that scoring tool. And so we really use trauma-informed care practices for patients that also report profound experiences of discrimination and racism. Yeah. Not just with patients that have adverse childhood experiences.
Yeah, so basically the preliminary results suggested that experiences with racism may be a bigger contributing factor to toxic stress than ACEs for our Black patients. So I think what that's telling us is that we really need to look at the structural racism that exists within the healthcare system and seeing how we can work to really create safe spaces for or Black mothers that's coming in, or Black birthing individuals that's coming in to receive services within these systems. So what we try to do at NAEBOR, like I said, we definitely try to do trainings to let our staff become more aware of just the experiences of just being a Black birthing individual in a society that really they are facing discrimination on a daily basis, and how when they walk into our clinic, the moment that they walk in, how we need to welcome them, and the importance of really being culturally responsive to their needs and really centering their voices. So we definitely are striving to break down the barriers that exist, within clinics and healthcare, in trying to really create that space where they feel comfortable. A lot of our patients are really happy walking in and just, they know us, they're able to be personable with us. They are saying how much they enjoy seeing people that look like them when they walk into the clinic. The fact that we have returning patients now, it speaks volumes to how well we're doing, and really the importance of creating spaces where Black birthing individuals feel like, they're part of the team and their voices is being incorporated into the type of care that they're receiving. And so, I'm learning how to really have better conversation just being there at the clinic. I'm learning how that not because we're all Black mean we have the same experiences, right? We are all individual and we all come in with different experiences. And so having our providers value that, and having the providers for our patient value the experiences that they are having is so vital to the care that we're providing. And walking in and doing the warm handoff and letting them know what to expect during their visit is so important to them. And some of them are expressing to us that they've never had the type of experience that they're having with the NAEBOR clinic before, especially the ones who have had children before. So again, just letting you know how vital it is to really create safe spaces for Black birthing individual within the healthcare system. And maybe some of the assumptions that we make, we really need to kind of check those and start to practice more with the experiences of the individuals coming in, in mind. So, yeah.
Absolutely.
Mhm.
So this is just a little bit of our learning curve. We think we're targeting the right patient population. We have an amazing team. We love the enthusiasm and the community support that we've been able to garner. We are here asking for referrals. We want to see more patients do more good. We are excited about our opportunities to collaborate with San Bernardino County Medical Society. We are working with, First Five as our grant funder and IHP, and are hoping that we can, if the governor budgets well and we vote well coming up, we're hoping we can create a sustainable care model. It doesn't break the bank. And so I think we're getting there. And then we just really know that we need to create a pipeline of Black and African American people to help them choose careers in healthcare. We have had a focus group. Kendra, you want to tell them what we learned?
Yeah, absolutely. I think our focus group was definitely, we've had two thus far. This one is based on the first focus group that we had. But one of the things that, well, not one, but this came up all the time where they say NAEBOR feels like home. It feels like family. And to every time our focus group members said this to us, we felt like, oh my God, like we're doing something right, where patients feel like they're able to come in and be comfortable. They know who we are. And they just are able to express and feel like they're a part of the decision making for their healthcare during their pregnancy. And so, the focus group has definitely been a good way of us getting feedback on how we're doing with NAEBOR. And those feedback, really, we're taking them to heart and doing the things that we feel the patient is liking the most and feeling like it's making a difference in how they're experiencing care. So far, our focus group feedback have been really positive. And out of that focus group, we've learned that they're interacting with all of the referrals. The patients have utilized doulas, and they're saying just how amazing it was for them to have doulas. We had two dads that I believe enrolled in the 24/7 dad program through the San Bernardino County Fatherhood, and they talked about just going to those groups and how, well, their girlfriends talked about the fathers going to those groups and how it was helping them to understand how to support them better going through the pregnancy period. So it's definitely been positive to be able to sit with our patients and have these focus groups and get the feedback from them on how we're doing and how we can definitely do better to improve whatever care that they feel we're offering. And it's definitely been positive. So I don't really have anything that I feel is bad to say thus far, but for the most part, I think our patients are very happy with the model that we're creating at NAEBOR.
I'm sure I'm preaching to the choir when I say that healthy childhood starts with being born better. And I appreciate all of the attention that you guys have given us today. We'd be happy to answer any questions. This is our contact information, phone numbers, and locations for both of our clinical sites. You can also check us out on the internet at neighborclinic.com or shoot us an email at neighborclinic@gmail.com. Again, thanks for hanging out over lunchtime on a Friday with us. If there's anything you'd like to know, we will get SBCMS a copy of a modified slide deck of the slides I'm able to share to send out to all of the participants. And I'm also happy to answer questions offline if you don't feel comfortable asking them here now.
Yes,
that was just amazing, you guys. That was really, really eye-opening. Thank you. And we're really happy to be a convener to kind of make sure that our practices out there are aware of you and how valuable you can be to their care plan and their care teams, access to care, and just really expanding opportunities and health for their patients as well as their scores. Let's face it, this helps everybody. So you're saving lives out there. There are a couple of comments in the chat, and one from Lydia is having a baby shower in the high desert, and she would like some flyers. So okay. So can you put your email in the chat, Dr. Roloff and Dr. Flores-Carter, and then maybe Lydia can email you directly about getting those materials.
Lydia, we'd be happy to get you some information and some flyers. Absolutely great. Love it.
Lydia, why don't you stick your email in there as well, if you would. And it looks like Curly Palmer has a question. Interested in knowing if mental health rose to the top for clients you served. We have seen an incredible need for increased perinatal mental health services, especially families wanting culturally congruent mental health care.
Yes, absolutely. That has definitely been a part of what we do with our patients. All of our patients are screened by getting the EPDS. And so if they score within a range that needs to have that social service consultation, they are immediately connected. And I think that's one of the things that really sets the bar high for our clinic, is because we're able to get our patients in to see and connected to behavioral health immediately. And I think that's a vital piece in maternal health, especially for moms who are experiencing symptoms of depression and anxiety during their pregnancy, right? That's a key component. And they've said so. Dr. McIntosh, our social worker, have explained just the patients are showing up for their virtual visits with her when they have those mental health, visits. And so that I know sometimes it could be difficult to get them, but whenever she's so great with them that they come back and they see her for their mental health visits. So yeah, it is a big part of what we're doing, Curly, is really connecting them directly to behavioral health services.
Fantastic. And I know you guys can
and
see.
I just want to call out to that point, it is really hard to get timely perinatal mental health services right now. It's taking, I think referrals are taking 6 months at times. So having that embedded mental health professional in the office setting is really what we found is the only way that we've been able to, get around those other barriers to accessing that service.
Mm-hmm.
That's great. And it looks like we have a lovely message here from Lanisha Johnson, thanks for your comments, Lanisha. And she says she's a coach for the Abundant Birth Project and a doula. So she wants to connect with you about getting some of their mamas into the program.
Absolutely, absolutely. If you can reach out, Lanisha, I put my email and then we can connect you directly to get you in to kind of talk to our staff and have an in-service where we learn more about your program. So yes, absolutely. Would love to connect with you.
Wonderful. Thank you, Lisa Love.
Mhm.
Black Infant Health continues to provide neighbor clinic information to participants. I'm sure they appreciate that. That's really awesome of you. And that's like what Dr. Roloff was saying. We really, really appreciate you guys kind of getting the word out with any of you who are in the role of providers and developing these care teams. So I think that's what's needed, just to make sure the awareness is out there. Dr. Roloff and Dr. Flores-Carter, now you're going to be opening your Redlands clinic, or that's on the horizon, or?
It's open.
Oh, it's
seeing
open now.
patient.
Okay.
Yeah,
Okay.
we'll have a kickoff event.
Oh, yeah. Okay.
It's,
Awesome.
It's in the works.
one thing at a time. But we'll
Oh
invite
my gosh,
all
yeah.
of you. We'll let you know.
Oh, yeah. It's a juggling act. And Curly Palmer has a question. How are you all engaging fathers in the perinatal appointments?
Yes, absolutely. That's a great question. We are encouraging our fathers be involved. We know how vital of a role they play with being involved in the care of the mom. And so we're definitely encouraging. We have dads that are in the room. We have done I guess training with them, with the dads and the moms for the crib setup. Like some of our moms are getting cribs, and we're able to demonstrate how to put the cribs up safely. And we've had several dads involved in getting that training. So we're highly encouraging of fathers being involved and going through that process with the mom. We don't want them waiting in the waiting room. They can come along and be beside mom and see, the treatment all the way through, because we feel like that's important, and they bring such a great support to that pregnant individual. So we're 100% encouraging of that.
Awesome. Does anyone else have questions? Well, we've got the experts here. And feel free, if you didn't put it in the chat yet, feel free to go ahead and just speak up or raise your hand. We can do it that way as well to make it more interactive. And I missed a comment from Deborah Waters. Thanks, Deborah, for your comment. And we appreciate you being on the board of San Bernardino Fatherhood. That's great.
Yeah.
Very cool. That's very useful.
Yeah, I know Ryan very well. I think Ryan is doing an amazing program, and we were always referring our patients to San Bernardino County Fatherhood. Like that's we have their flyers that go into their admissions packet. So yeah.
Awesome. Well, I'm not seeing any
He asked
other.
me to attend. Ryan did ask me to attend, so that's why I'm here. And you guys have done a wonderful job. A wonderful job.
Thank you.
That's great. That's nice. It's nice. You guys already have a relationship. Yeah, so please help us. Like we say, feel free to get the word out here and really communicate with some of your partners and colleagues about how beneficial this interface is. And NAEBOR Clinic, we thank you so much for what you guys are doing for really transforming health and not just for our current population, but for the future, for all these babies for whose health you're improving. And we want to thank Dr. Kristy Roloff very much for being here. That was fantastic. And thank you, Dr. Kendra Flores-Carter. Appreciate that very much, and your entire team. So last call for questions. Anybody? You sure nobody has any more comments or questions? Okie dokie, then we're gonna let you all go. Thank you all so very much, you guys, for joining us. And like Dr. Roloff said, we'll send out a modified slide deck. We'll send out the recording and have a lovely weekend, everybody. We will see you all again real soon. Thanks for all the work you do.
Thanks all.
Thank
Have
you
a
so
great weekend.
Bye, you
Bye-bye.
guys. You too.